All right. Well, welcome everyone. Thank you for joining us for the May 22nd, 2024 Long-Term Care Town Hall, Understanding Enhanced Barrier Precautions. We are very thankful for the support and collaboration of the Centers for Disease Control and Prevention's Project First Line, which has enabled us to provide this webinar to you all as quickly as possible after learning about the recent EBP enforcement memo. I'm Commander Kara Jacobs-Slifka. I'm a medical officer with the CDC's long-term care team. I lead our long-term care team here within the Division of Healthcare Quality Promotion. I'm really excited to introduce the two members of the long-term care team who we will be presenting this webinar, Drs. Bola Ogundimu and Heather Jones. Dr. Ogundimu is a nurse infection preventionist and health scientist. In her role, she provides consultation and technical assistance for implementing infection prevention and control strategies in post-acute and long-term care settings, in collaboration with state and local health departments across the United States. Dr. Ogundimu currently leads work focusing on the intersection between health disparities and infection prevention. Dr. Heather Jones serves as a nurse consultant, having begun her healthcare career as a registered nurse in acute care, and then as a family nurse practitioner working alongside medical directors and staff in nursing homes. In 2020, she received her doctorate in nursing practice and began her public health career with CDC. Dr. Jones provides infection prevention and control subject matter expertise for post-acute and long-term care outbreak responses, and has presented at many local and national conferences. Dr. Jones is currently leading efforts for better understanding the role of infection preventionists in long-term care settings.
All right, and I've already shared our disclosures, so I will not repeat those. Thank you everyone for joining us again today. I'm going to now do a little bit of a presentation of the iceberg effect. And many of you that have been in our long-term care calls before, as well as know anything about infection and colonization and MDROs, will be quite familiar with the iceberg effect. So to begin, when we think about the iceberg and we think about the tip, this is the tip of the iceberg, and this is what we see. And so the tip of the iceberg is clearly visible to everybody, and it depicts what we already know, or what we physically see or know about a patient or a resident. An MDRO infection is the tip of that iceberg. And when a person has an MDRO infection, they have presence of signs and symptoms in the resident or patient. Or another way to look at this is if a person has a documented infection or colonization with the MDRO, and it is present in their healthcare record. So you see this and you know this. It isn't a part of what we know as the larger unseen part, what we don't see or we don't know. And this is the large portion that's hidden below the surface. This is what we often discuss when talking through an MDRO colonization or multidrug-resistant organism. An MDRO colonization is when a resident has the presence of an MDRO that is not causing signs and symptoms, or it's not present in their medical record or their healthcare record, so you do not know that they are colonized with an MDRO. And here is the whole picture. So when we think about the whole picture, this is where the prevention strategies come into play. If you don't see or know the large unseen portion of MDRO colonization, and you're only aware of the few residents who have a known MDRO infection or colonization in a nursing home, you must have prevention strategies in place to stop the spread of all unknown MDROs. A recent study found that only a small portion of residents in the study were already known to have an MDRO. But when they began to actively look for MDROs in these residents of these nursing homes, they actually found that 1 out of every 2 were found to have an MDRO. So we wanted to establish the basis of why there is an importance for having prevention strategies, including enhanced barrier precautions. And now I'm going to turn it over to Bola, who is going to be speaking a little bit more about those.
Thank you so much, Heather. And so for exploring again, like our rationale as well as our exploration of enhanced barrier precautions as noted in the next slide. So we have enhanced barrier precautions as an infection prevention and control strategy that is really designed to reduce transmission of multidrug-resistant organisms, otherwise known as MDROs, in our nursing homes specifically. So EBP, which is Enhanced Barrier Precautions, it involves, again, the use of gown and gloves that is focused on resident care activities, most likely leading to the spread of MDROs in our nursing home facilities. Next slide, please. So as a refresher, going through the different types of precautions that we have, starting out with the standard precautions, we recognize that standard precautions appear or apply to the care of all residents, where the use of PPE is really based on anticipated exposure to blood, body fluids, secretions, as well as excretions. So for instance, gloves are recommended when someone, a healthcare personnel, will be in contact with blood or potentially infectious materials, mucous membranes, as well as non-intact skin or contaminated equipment. If it's anticipated that that interaction will occur. Again, that is standard precautions. And so in contrast, or sometimes in complements with our enhanced barrier precautions, which is the use of gown and gloves beyond the anticipated blood and body fluid exposure. And again, enhanced barrier precautions focuses on gowns and gloves that are used during high contact resident care activities that have been shown to result in to decrease transfer of MDROs to hands and clothing. So again, to prevent transfer of MDROs to the hands and clothing of healthcare personnel, even if blood and body fluid exposure is not anticipated. Point to note is that standard precautions would still apply even when you're using EBP. So for instance, if it's anticipated that for a procedure, there will be splashes or sprays or interaction with the residents, if splashes or sprays are anticipated during high contact resident care activities, face protection really should be used in addition to the gown and gloves. So essentially standard precautions plus enhanced barrier precautions, where you anticipate that there's another level of body fluid exposure. Next, we have contact precautions, and that actually requires the use of gown and gloves on every single entry into a residence room, regardless of the level of care that is being provided to the resident. So contact precautions are generally intended to be time limited. And when they're implemented, there should be a definitive plan, or at least a possible plan, for discontinuation or de-escalation of the contact precautions. And then the resident is actually given a lot of times dedicated equipment, the stethoscope, blood pressure cuff, sometimes Dynamax, and is placed in a private room setting, specifically for contact precautions. And then we also say when private rooms are not available, some residents, typically we say group-like residents together. So some residents may be cohorted or grouped together. And then also residents of contact precautions should be restricted to their rooms except for medically necessary care And they are also restricted from participation in group activities. So again, those are the contrasts between standard precautions, enhanced barrier precautions, and contact precautions. And just reiterating again, enhanced barrier precautions will be gown and gloves used, but if you anticipate there's additional like body fluid exposure, then standard precautions would also be used in addition to enhanced barrier precautions. Next slide. So at a minimum, enhanced barrier precautions are intended to be used for residents colonized or infected with MDROs targeted by the CDC. We've often gotten questions about what do we mean by CDC targeted MDROs. So I'll be going over that the next couple of slides. So for the next slide, so what do we mean by a targeted MDRO? So essentially, targeted MDROs are germs that are resistant to most or all available antimicrobial agents and have the potential to spread widely. And intensive public health actions are typically required to slow the spread of targeted MDROs. And next slide, we have a couple of examples. So just off this list on the slide, we have pan-resistant organisms, which I mentioned earlier, as well as carbapenemus producing carbapenem-resistant Enterobacterialis, and then also carbapenemus producing carbapenem-resistant Pseudomonas species, and also carbapenemus producing carbapenem-resistant Acinetobacter baumannii, which also some is known as crab, and then Candida auris is another example. So next slide, it is important to note that in addition, residents should have MDRO prevention strategies in place for residents at an increased or higher risk of being colonized or already colonized or infected. And we would be using EBP for residents with indwelling medical devices, essentially as an MDRO prevention strategy that could be used or that may be used for this group of residents with increased risk. So the first increased risk would be for residents with indwelling medical devices, such as indwelling Foley catheters or indwelling urinary catheters, tracheostomies, ventilator, as well as central venous catheter, like PICCs or ports. And then for the purposes of ABP, we have also added midline catheters in addition to that. So next slide, we have also EBP may be used for residents that have a wound. So we've gotten a lot of questions about wounds, like what do we mean by wounds? So we're not talking short-term wounds that you can apply a Band-Aid kind of dressing on. We're talking more chronic wounds like pressure ulcers or diabetic foot ulcers, as well as chronic venous stasis ulcers, as we recognize that chronic wounds are risk factors for MDROs. And so the other next slide we have is just thinking through our EBP versus contact precautions. So we've often gotten questions about, well, who needs contact precautions instead of enhanced barrier precautions? So to answer that question, again, recognize that EBP is specific for MDROs prevention, specifically in nursing homes. And so Appendix A of the isolation guidelines would still apply for other pathogens. So in your facility or in any facility, specifically nursing home, if a resident, for instance, has certain conditions where there might be possible transmission, if not contained, then contact precautions should be implemented. So those examples would include for a facility that has residents, for instance, with acute diarrhea, for those residents, contact precautions would be in place, as well as residents that have draining wounds that can't be contained or covered, like they have weeping wounds, contact precautions would be implemented. And then also, if there are conditions where the resident is unable to contain their excretions, for instance, the cases like C. diff, or even norovirus, where they might have explosive diarrhea, then contact precautions would be implemented. And again, it's just secretions or excretions that can't be covered or contained. Next slide. So we also have situations where, as I indicated earlier, other situations outside of not being able to contain or cover, whether it's a wound, weeping wound, or excretion, also have situations where if a facility has a suspected or confirmed MDRO outbreak, in working together with the public health department, and oftentimes it is directed by the public health department or public health authorities investigations, that contact precautions is in place again for a time limited period. And this is generally intended, again, to be time limited. And when implemented, there should be a plan for discontinuation or de-escalation. And also, not all MDRO outbreaks will need the use of contact precautions. Again, we encourage you to work with your public health department to really go through the different steps of your outbreak investigation in collaboration with them. Next slide. So we've often gotten these questions regarding what the CDC defines, or, it gives examples of high contact resident care activities. So those activities include, first off, things like dressing, bathing, or showering, as well as transferring the resident from one spot to the other, from bed to chair, and vice versa. And also providing hygiene and changing bed linens, as well as changing grease or assisting a resident with toileting, as well as handling their indwelling medical device. And also, if we're going to be assisting with maintaining their indwelling medical devices, their gowns and gloves would be needed for those circumstances. And again, when we talk about wound care, as I illustrated earlier, we don't necessarily mean the shorter lasting Band-Aid wounds. We're talking more chronic wounds. And a lot of times we often say that those resident care activities that are shown on this slide, the high contact resident care activities, should be bundled as much as possible. So if you're doing AEM care, it is important to consider what else you can have in place, as maybe being able to group together the different activities that can be done. And the next couple of slides will show certain examples of what can be done for facilities while they're bundling different resident care activities. Next slide. Okay. So again, many of the high contact resident care activities are typically bundled inside the room as part of AEM or PM care, as I noted earlier. So for instance, on the left side of the slide that is circled in red, activities such as helping the resident use the toilet or toileting, helping them getting freshened up, as well as helping them get dressed or change bed linens, and transferring the resident from bed to chair, vice versa, can be bundled together during one interaction with the resident. So otherwise, we call it AM care in some instances. In another instance on the right, activities such as assessing wound care, dressing or changing wound dressings, as well as performing skin assessment, and also assessing their feeding tubes or giving medications through their feeding tube also can be bundled together or can be provided at certain intervals rather than just using a single entry into that residence room. So next slide we have, again, EBP is generally not necessary for brief, minimal touch interactions with the resident. And also, if the healthcare personnel is not necessarily touching the resident or environment inside the room, then EBP is not needed. So for instance, if there is anticipated isolated foaming of the resident's hair, that is not all otherwise bundled with other high contact resident care activities, then that interaction would not necessarily need gown and gloves. Essentially, no EBP needed for that foaming isolated instance. Next slide. So again, as to why we have EBP being recommended, we've looked at multiple studies over the years, and over the next couple of slides, we wanted to share different studies that have looked at high contact resident care activities that have resulted in the highest spread of MDROs. So as you can see on this slide with the bars, the highest risk activities included those where we recommend gown and gloves to be used in the current EBP recommendations. Again, these slides will be available to everybody after the town hall. Next slide. We also showed similar results with other studies that others have done, really indicating the highest risk activities that caused the most MDRO spread. Again, the importance of having data from these nursing homes cannot be overstated. So observations of the types of care activities that are performed in nursing home residents and which activities were found to be the highest risk of spreading MDROs to healthcare personnel, which could then spread to other residents or even themselves, really directly informed our EBP guidance. And then we have the next slide, sir. So with the previous studies that I had noted earlier, again, really these high contact activities have the most spread. But this particular slide, this particular slide denotes like how targeted gown and glove use, also known as EBP or Enhanced Barrier Precautions, successfully reduced the transmission of MDRO. So this study in particular demonstrated that nursing homes were able to successfully identify residents with risk factors for MDROs, as I indicated earlier, and also obtain excellent adherence to the focused use of gown and gloves, meaning EBP, by healthcare personnel during these high contact resident care activities. And again, these results that we have on the slide showing on the bar indicate that EBP was an evidence-based approach for preventing the transmission of MDROs. And additional related studies are ongoing right now to continue to support our ongoing understanding of the most effective approaches to preventing MDRO transmission in nursing homes. So again, nursing homes have successfully identified who met EBP, as well as successfully been able to have adherence to gown and glove use within their different facilities. And so we have had our partners share the possibility of having EBP implemented and the successes that our partners have found, as well as challenges that our partners have been able to identify with implementing EBP at our nursing homes. So with that said, I will hand over to Heather to talk about why we need EBP as part of the MDRO prevention strategy. Thank you, Heather.
Thank you so much, Bola. I'm now going to discuss why it is needed. Why do we need enhanced barrier precautions as part of an MDRO prevention strategy? First, nursing home residents are at the highest risk and higher risks for not only having, but getting an MDRO colonization or infection. A majority of people who live in nursing homes are older, and as a person ages, the body is less able to fight infection as they would have been when they were younger. Most have multiple comorbid conditions, such as high blood pressure, chronic kidney disease, or chronic respiratory conditions. Nursing home residents also depend on many of the staff members to help them with caring for themselves, whether through physical or cognitive limitations. There is also a high social context within nursing homes, and multiple interactions occur between both residents and staff. Other higher risk factors that affect the likelihood of MDRO spread is that a lot of the residents have had a recent or a long hospital stay. They have wounds and indwelling medical devices. A majority of nursing homes in the United States continue to have multi-resident rooms with up to 4 residents together in one room. There is also a continued overuse of antibiotics in our nursing home residents, which all can place them at a higher risk of acquiring an MDRO. So how can you be successful in implementing enhanced barrier precautions? It starts with robust and foundational prevention strategies, along with enhanced barrier precautions. From cleaning your hands to environmental cleaning and disinfection, auditing practices, and good communication. First, very foundational information, but also very important, is to emphasize cleaning your hands, especially before and after any care with a resident or patient, or after using or touching equipment in their environment. Alcohol-based hand sanitizers continue to be the preferred method for cleaning your hands when they are not visibly dirty, and when your hands are visibly dirty, clean your hands with soap and water, and make sure that staff has easy accessibility to the products they need to clean their hands appropriately. Next up is cleaning and disinfection. Although many times seen as a primary duty of environmental services staff members, cleaning and disinfection is important for everyone to take part in. Make sure high-touch surfaces are cleaned and disinfected at least daily, and reusable equipment must be cleaned and disinfected after each and every use. Work with others in your community or facility to reduce the number of cleaning and disinfection products you are using, while also ensuring the most appropriate hospital-grade products are being used, and develop, maintain, and use a Who Cleans What list so that everyone on the team knows who is responsible for which items. Next is a brief discussion about auditing. Auditing is your way of knowing if the education you have provided to staff is being implemented and done appropriately. This should happen with all aspects of infection prevention and control, and include hand hygiene audits, how well are PPE being taken off and put on, also looking at the cleaning and disinfection practices, and not only at those high-touch locations, but also daily and terminal room cleans. And audit your communication practices of the staff members And as important is to share the feedback with your staff so they know if there are opportunities for improvement and acknowledging when challenges have been overcome. Communication is the final piece of the prevention strategies I wanted to discuss. Communication should not only occur within the units of your facility, but also with outside partners. Find and use a communication tool that works for everyone across the community, and make sure pertinent information is shared as we are all connected. Here are a few more tips to help you with initial implementation of EBP in your facility or facilities. Provide initial and ongoing education to everyone who comes into, works in, or lives in your community or facility. Include all staff and all shifts. Don't forget to provide education to the overnight shifts and the weekend staff. Create a robust rollout plan and use the tools that have been developed. Don't reinvent the wheel. Many of the tools can be customized so you can tailor them to your unique community. Start by using the CDC pre-implementation tool and make sure to first identify a method which residents need EBP initiated, and then how best to maintain this record. Now I want to show you just one example of what can happen when any one of these prevention strategies are missed. You have an acute care hospital, which has a known MDRO outbreak. And patient A and patient B arrive for care. During patient A's stay, they acquire an MDRO. Then patient A and patient B transfer out to a long-term acute care hospital for further care. Patient A brings that MDRO along with them. Well, through poor preventive practices, patient B now also acquires or gets the MDRO. Well, after a little bit of time, they part ways, and patient A goes to a skilled nursing facility, or SNF 1, and takes the MDRO along with them. Patient A, or now resident A, meets resident C and resident D. Through bad practices and not following appropriate and adequate prevention practices, now resident C and resident D also have acquired or gotten the MDRO. And let's not forget resident B. Resident B went to SNF 2 and took the MDRO with them as well. So then resident B meets resident E and resident F in that SNF 2. Through poor prevention practices, once again, resident E and resident F acquire or get the MDRO as well. So due to prevention practices not being followed, such as a lapse in communicating MDRO status, perhaps staff weren't cleaning their hands after providing care to the patient or residents. Once they got to the SNF, maybe they didn't put them on enhanced barrier precautions and they had an indwelling medical device that necessitated them being on it. Someone didn't clean and disinfect as was required, or there's an absence of auditing in any one of these locations. So what happened was that what was only one MDRO colonization or infection at the acute care hospital has now become 6 MDRO colonizations or infections across 2 separate long-term care facilities. And as I shared, this is only one brief example of how MDROs can spread across healthcare communities. Which brings me to my final slide, and that is to emphasize enhanced barrier precautions being a method to balance safety of the residents with maintaining the residents' quality of life. We know MDROs are common in nursing homes, and an MDRO colonization can lead to serious infections and even death in our residents. Implementing strategies such as enhanced barrier precautions can prevent the spread of MDROs while considering the unique aspects of nursing home care and socialization. While in other healthcare settings, the answer is to use contact precautions for MDRO infection or colonization, a nursing home is not an appropriate setting for long-term prevention of MDROs with contact precautions, as it would see residents not being able to maintain a good quality of life because they would be restricted to their rooms except for medically necessary care, as well as being restricted from being able to participate in group activities. Enhanced barrier precautions is a prevention strategy that balances each of these together: prevention of MDRO spread, maintaining resident safety, and improving a resident's quality of life. As we shared previously, the slides will be made available after our webinar and town hall, and these are a few of the links updated since our recent Clean Slate CDC.gov updates. And these provide some of our educational videos that are available on this slide. And then these are enhanced barrier precaution tools that can help you with implementation, as well as letters that you are able to customize for residents, families, staff, and nursing home leadership. We've also developed posters and a pocket guide that can help you with staff development and ongoing education. I will now turn it back to Kara, who will moderate for any questions. Thank you.
Thank you so much. I want to give a special thank you to Dr. Ogundimu and Dr. Jones for walking us through this webinar. I have been taking note of the questions that are coming in. We will do our best to try to get to as many of those as possible. I may combine some of them and try to give an answer that will hopefully help with the related questions that we are seeing coming in. So, to start, I think we have had a couple of questions that have been specific to wounds. So I think let's go ahead and start with clarifying what wounds would be an indication for enhanced barrier precautions.
Thanks, Kara. And that's a pretty great question. So our EBP guidance describes that all residents with wounds would meet the enhanced barrier precautions guidelines. However, the intent, again, of our EBP guidance is to focus on residents that have a higher risk of acquiring MDRO over a long period of time. So not just hours, right? And so within the enhanced barrier precautions, frequently asked questions or FAQs, we actually expand more on describing the focus on residents with chronic wounds and not the short-term wounds, like the Band-Aids, quote-unquote, ones, as I noted earlier. So it's more chronic wounds that include your pressure ulcers as well as diabetic foot ulcers and chronic venous stasis ulcers.
Thank you. So the focus being on chronic, longer lasting wounds. And then you started to mention, are there wounds that are not considered to be an indication for EBP?
Yeah, thanks, Kara. So yeah, your shorter lasting wounds, as I indicated earlier, the Band-Aid wounds or the skin grades or skin tears that are again like covered like with a small dressing or shorter period of time or anything similar in terms of the dressing would not be an indication for EBP. Again, it's a shorter time kind of wound. And so we did actually have fielded questions from different facilities as well as HAI programs about healing post-op surgical wounds. And that specifically healing post-op surgical wounds would not be an indication for EBP.
Thank you. That has come up a few times in the Q&A on the webinar today. So, while there isn't a definition for the exact amount of time that a wound must be present to become colonized, we recognize that the longer a wound is present, the more concern we have that these wounds may become colonized with an MDRO. And so in situations where underlying medical conditions lead to chronic, poorly healing wounds, our concern level increases that those may become colonized with an MDRO. So I do also, because again, a few questions have come up. I think this is related to wounds. There are a few questions about ostomies specifically. Are those considered to be wounds?
Thanks for that excellent question, Kara. No, ostomies, and when I talk about ostomies, I'm referring to like colostomies and ileostomies. These are not considered to be wounds for enhanced barrier precautions. And to help clarify this commonly asked question, we have also updated our enhanced barrier precautions frequently asked questions page to specifically address ostomies so that you'll have a way to refer back in case you have questions that are brought up. Now, ostomies are not considered to be wounds, but for EBP purposes, but if they have an indwelling medical device, so like if you're thinking about a tracheostomy tube or a percutaneous nephrostomy tube, those would be an indication for EBP because there's now a component that's communicating internally and externally, which places them at a higher risk of getting an MDRO or even acquiring one.
Thank you, Heather. One of the other common questions I've seen about throughout the chat has been asking about physical therapy, asking about therapy, in a therapy gym. There have been numerous questions that have brought up therapy and wanting us to clarify a little bit more here. And we definitely recognize that physical therapy encompasses a wide range, and not just physical therapy, occupational therapy, therapy activities. There are a wide range of activities, and they are not specifically called out as high contact resident care activity. So can you talk a little bit about whether physical therapy or therapy is considered to be high contact? Should therapists be using PPE?
Yeah, thank you so much, Kara. So depending on the activity, therapy may be considered a high contact resident care activity. And again, we say therapists should use gowns and gloves when working with residents on EBP in the therapy gene. That's ideal. Or in the residence room, if they anticipate having that prolonged close body contact where transmission of MDROs to the therapist clothes is certainly possible.
And so as a follow-up to that, what if the therapy can't be performed in the therapy gym or in the resident's room? Or as some examples in the chat have shared, what if the resident needs assistance walking from their room to the therapy gym or in the hallways? Is it okay to use PPE in the hallways?
Yeah, that's a great follow-up question. So EBP really should not limit a resident's ability to continue their medical therapy. That is critical, right? And so while the use of gowns and gloves is generally discouraged in the hallways and other common areas, there may be individual circumstances like therapy that has to occur outside the residence room or outside the therapy gym that would prompt an evaluation for the need of PPE outside of the room or the gym, really depending on the level of assistance or close contact that the therapist or anybody helping out with therapy will be having with the residents.
And I also wanted to add a comment here that we understand and we know that there is a lot of gray area when we talk about these situations. And when it comes to infection prevention in general, and not just with the practices of enhanced barrier precautions, because we understand that even the most seasoned infection preventionists are going to be faced with new, different situations. And you will need to evaluate those situations based on your expertise as they arise, and then make the best determinations based on best practices for both the residents and the healthcare worker safety.
Thank you both. I want to shift the topic a little bit to talk about midlines, because there are multiple questions that have come in during the webinar specific to midlines or midline catheters, and asking for more explanation in terms of, are these considered to be indwelling medical devices for the purposes of enhanced barrier precautions?
Yeah, thank you so much for another great question. So yes, midlines, in addition to central venous catheters, so your CVCs, that include your ports or PICC lines, are considered indwelling medical devices for the purposes of EBP. Yes.
And thank you, Bola. Can you expand upon that a little bit? Some of the questions have asked, since peripheral IVs are not included as indwelling medical devices for EBP, and can you share a little bit more about why midlines are considered an indwelling device?
Yeah, great follow-up. So more importantly, residents who have midline catheters as part of their medical therapy, often complex, right, tend to be residents with additional risk factors for MDRO colonization. So similar to central venous catheters, PICC supports, these midlines may remain in place for an extended period of time, again, longer period of time, often up to 4 weeks or more, and they're thereby increasing the risk of an infection or MDRO acquisition.
Thank you, Bola. I'm seeing numerous questions asking for us to expand a little bit more on the brief contact that was mentioned during the webinar. So can you expand, are one of you able to expand a little bit more on what those situations might be, particularly inside of a resident's room who's on EBP, where limited enough contact occurs between the resident and nursing home staff that PPE might not be indicated?
Absolutely, Kara. Thank you. So we've been asked about situations. One example is like going into the resident's room and helping them put on a sweater, or going in to just do a minimal transfer and it's brief contact that occurs, or even if you're individually going in to brush someone's hair. These are examples of activities that Bola shared previously that are constantly bundled together as part of morning or evening care, rather than occurring as those multiple isolated interactions throughout the day. When bundled together, it would be an indication to wear a gown and gloves, because you're having that prolonged contact care with the residents while you're bundling it together. But if you're in there for an isolated activity, you're having a short, brief interaction, contact with the resident, this would not generally necessitate the need for using gown and gloves.
Thank you. So similarly, while the presence of, similarly, I want to ask a little bit about this question related to an indwelling medical device. So we know that indwelling medical devices are a major risk factor for being colonized with, or being at risk for becoming colonized with an MDRO. Can you talk a little bit more about use of medical devices that might only involve limited physical contact between a healthcare worker and a resident, and use of gloves and gowns in that type of situation.
Yeah, thanks, Kara. I am happy to expand on that a little bit. One example that I like to give is that, say you have a staff member that's going to pass medications through a feeding tube. And although this is only appropriate if the activity is not bundled together with other high contact prolonged care activities, and there's no evidence of ongoing MDRO transmission in the facility, the safest practice would be to wear a gown and gloves for any care or use of an indwelling medical device. But facilities can define these limited contact activities in their policies and procedures and educate healthcare personnel so they can ensure consistent application of enhanced barrier precautions when it comes to these brief interactions that occur.
Thank you. I want to comment, or I want to ask you to comment also on PPE storage. So speaking about PPE, where should PPE be stored with EBP?
Yeah, thanks, Kara. This question has come up often. CDC continues to recommend that PPE is located immediately outside of the resident's room or at the entry to the resident's room. And we've discouraged the practice of storing the PPE in the room primarily because there is a risk of contamination. This is one specific question where many of you have pointed out previously that CDC and CMS have responded slightly differently. However, our key message aligns. PPE should be readily available for a staff member to use when they are planning to provide high contact resident care. And whether stored inside or immediately outside of the resident's room, the facility should make every effort to avoid contamination of that PPE.
Thank you, Heather. Now, I know we are nearing the end of our time, but I did see that there were a couple of questions specifically asking about the studies that were shared, and these are available in there are resources that we will include with these slides, and they are also available on the CDC EBP webpage, so you can take a look and review in more detail. I did want to ask, the Washington State Department of Health had shared with us an analysis done looking at cost effectiveness of EBP. Bola, very quickly in the last minute, are you able to share briefly what they've learned?
Sorry. Yeah, so with Washington State HAI program, and I don't see him on the call, but that's okay. So they had done a cost analysis of skilled nursing facilities using enhanced barrier precautions, looking at their implementation, like how much it costs versus the cost of contact precautions, implemented contact precautions in a CORS outbreak investigation. And the specific nursing home that they looked at was 100 beds. And they had 10 different residents essentially that had Foley catheters that would have met the enhanced barrier precautions implementation criteria. And they also learned that if they looked at residents needing the indication for contact precautions, that again, looking at the cost, the aggregate costs, they determined that they would need an RN to provide 6 contact care activities per resident per day, with the CNA providing 4 contact activities per resident per day, and cleaning products also for CORs that have to be specifically noted with the kill clean, as well as the germicidal bleach wipes for CORs, and also screening time for staff or resident, depending in terms of what residents were CORs positive. So they overall determined that for that specific instance in implementing contact precautions, they would have to spend about $945 per resident in that isolation room. And again, like, I don't see Carolyn on the call, but If you guys would like more information about their study, please feel free to reach out to your HAI program. But it was shared by Washington State HAI program.
Thank you, Bola. And I want to thank the audience again for joining us today. Thank you to our speakers, Dr. Bola Ogundimu and Dr. Heather Jones. Greatly appreciate you sharing with this audience today. And we will be working on putting all of this information on the web so that you are able to refer back to us. Thank you so much again for joining us.
And just real quick, Kara, I wanted to respond. There's been a lot of people that are asking about the link for the FAQs. The best that I can share now is if you will go into your search engine and type CDC Enhanced Barrier Precautions. You will be able to get to our primary slide, and you scroll all the way down, and then it will take you to a link that says frequently asked questions. That is one of the best areas to find more defined answers to many of the questions that have been asked today.